Yes, so I see that we are live. So it's a warm welcome here from my side, from Berlin. So my name is Ralf Langhoff. I'm interventional angiologist from Berlin. I welcome you to a CLI session. It should be a very interactive session. So we have very nice and very skilled panelists here. It's Mariano, Palena from Italy and Tibor Balázs from Bratislava, Slovakia. And we will just have some introduction from my side, and then we'll have two very interesting lectures on the topic of CLI treatment. So for you in the World Wide Web, you just have the option to pull questions. We will try also to cover the questions within the lectures, and also after the lectures, we will just have the opportunity that I can try to get your questions to the both panelists here, and also will try myself to answer your questions. So there will be also polling questions in terms of your expectations. So, but you will just you can use this Zoom tools. Just start with this polling questions. So meanwhile, I'm just talking. You can already try to poll. So which of the following are your main challenges when treating CLI patients? It's a multiple choice one. So understanding which patient can benefit revascularization, understanding which device to use when, access to relevant resources, to learn about techniques and tools, get patient referred earlier, and managing complications surrounding these patients. So right now you can vote if you like to this polling. Okay, so I don't know whether you are aware of this. Quite interesting. So most of you just voted for understanding which patient can benefit revascularization, or understanding which device to use. And I think just if I just look for myself, I think also these are just my main questions right now. So I don't know whether you're aware of this global CLI society, which is just something new, but I think it's quite important to have this because I think it's a global problem. And if you just look this diabetic burden here on this land card here, you see that there is a huge number of diabetic patients, and a lot of those diabetic patients run to CLI situations if they are not taking well care of their general diabetic problem. So the CLI burden, to me, I think we just have to face several problems. One problem is that patients' awareness still is very low. So patients mostly don't know anything about their CLI status. The social acceptance of this problem is even lower than the patient's awareness, because you can talk about your myocardial infarction, but definitely most people don't talk about a gangrene or an ulceration on their foot. Beyond the problem of CLI in terms of just how to treat it, I think we have to be aware that the mortality rate of these patients is very high. So only lung carcinoma has a higher 5-year mortality rate compared to CLI. So it's a really, these patients are very sick and very diseased. So we still, I think a lot of efforts were already done in terms of CLI treatment, but amputation still is a major burden, and the costs which are related to these amputations and to home care of those handicapped people are rapidly increasing. So I think it's very important that we just have to do something against this. Physicians training in open surgery and endovascular therapy still, I think, has room for improvement, and this webinar is also dedicated to address this topic so that we all can improve, we and also the audience here. It does make change also something on the survival rate. So we all saw that this is not affecting the survival at all, but you see here, the 2 lines ahead are just from recent publication from Jihad Mustafa, that it doesn't matter whether you are primarily treating those patients by surgical approach or by endovascular approach, but you're definitely doing something on the survival rate compared to an amputation. So try to treat those patients who definitely will also change the survival rate of these of your CLI patients. So getting just not spending too much on introduction, I think I would pass the ball to Mariano Palena. I think he's a well-known expert worldwide in terms of CLI treatment and also non-endovascular treatment in general. He is working in Abanoterm, and probably, Mariano, you can briefly introduce yourself.
Well, thank you, Ralf. Thank you to everybody to be connected, and thank you, Boston, to invite me to participate in this meeting. I'm Mariano Palena from Abanoterm. I'm an interventional radiologist dedicated for CLI treatment. The topic of today is to discuss about the successful BTK revascularization techniques. And well, as Ralf mentioned during the introduction, we are going to talk about the very sick patients affected by multi-level and multi-vessel arterial disease with 80% of tibial arteries involvement and 50% of foot arteries involvement. When we discuss about that, we talk about CTOs, really long and many times calcified occlusions. It's important to approach these patients. It's very important to know the anatomy, the vascular anatomy, considering that we can divide it in dorsal circulation, plantar circulation, and the arch that connect both circulation. And it's important to know how to study it to understand properly which vessel is going to feed the lesion or the ulcer in the foot. Why this is important? Because it allows us to set up our intervention, considering that the dorsal circulation is going to feed the dorsal part of the foot, the first and second toe, and it's the biggest angiosome that we have in the foot. And considering that the posterior tibial and plantar circulation is going to feed through the median plantar artery, the median part of the foot, and the first toe, and through the lateral plantar artery, the lateral part of the foot, and the fifth and the fourth toe, primarily. And considering that we also have through the posterior tibial artery a calcaneal branches that are going to feed the calcaneal region. And finally, the last angiosome through the peroneal artery that is going to feed the calcaneal part of the external part of the calcaneal region. So knowing the anatomy is important to set up the procedure. This video summarizes all the angiosomes that I really mentioned now, considering different arteries and different branches from different arteries that are going to feed different regions. Another important thing is to consider which should be our target, and we can divide the revascularization in different strategies. The direct strategy that is trying to give direct blood flow for the ulcers, like this case, vessel foot with occlusion of everything. I was able to recanalize dorsalis pedis and the first metatarsal branch for the first and second toe. I obtained this type of result. The patient was suffering a minor amputation and healed. So direct revascularization is to open the artery that is going to directly feed the gum. This is the real angiosome concept, and is indicated in ulcers that involve only one angiosome and in patients that are scheduled for minor amputation but not for a forefoot amputation. In the opposite side, what we have is the complete revascularization, like in this case with occlusion of anterior and posterior tibia and distal occlusion of dorsalis pedis in a very complex clinical situation, in which I successfully opened anterior, dorsalis pedis, and posterior, and the patient healed after 6 months. And this more aggressive and more complete strategy is indicated in patients with deep infections that involve more than one angiosome, so we cannot decide which artery is going to feed specifically every angiosome, and at this point we need everything or as much as possible. And also this strategy is indicated in patients scheduled for forefoot amputation. And finally, we have the last option, that is the indirect revascularization, that we never start setting up a procedure through the indirect flow for the user, but this is the option we have when we fail to do the direct revascularization, like in this case in which I failed to do the posterior and failed in the plantar artery, as you can see the contrast out. So I was able to recanalize the anterior and the distal dorsalis pedis, and finally the patient had flow through the collaterals. There is a paper that demonstrates that the restoration of the blood flow through these collaterals provide good results in terms of healing and limb salvage. In our experience, the time for healing is longer with an indirect revascularization. Crossing strategies, I usually start with an antegrade access in the common femoral and start approaching the lesions in an endoluminal approach. If it fails, we shift for subintimal. And finally, if the subintimal fails, we have the retrograde options that can be through the percutaneous access or just using the pedal plantar or some collaterals. But most important thing, no crossing, no party. If we are not able to pass a guide wire, we cannot open, we cannot treat the arteries. This is a case, it's an example case about a female, 86 years old, with many comorbidities that was previously amputated in the fifth toe and arrived to our center with a necrosis in the base of the amputation. This is the picture after the revascularization, in which I did an antegrade access in the proximal SFA. And as you can see, it's a multi-level, multivessel arterial disease with many stenosis in the SFA and then a pop, occlusion of anterior and posterior tibial, and only patent peroneal artery and a good dorsalis pedis with a dorsal circulation. But there was no direct blood flow for the foot, and there was no direct blood flow for the fifth. So from the beginning, the setup was to approach, following the angiosome concept, posterior tibial, V18 and 4 French catheter, endoluminal and subintimal, but finally I finish in a vein. So rather than to stop there, I leave the guide wire in place and approach anterior tibial, again V18, 4 French Bernstein type 2 catheter, and again mixing endoluminal and subintimal that finally allow me to reach the foot and to re-enter in the dorsalis pedis. When I re-enter, went down with the 4 French, check, demonstrate the re-enter and shift for an 014 guide wire. I always prefer to cross the foot arteries with an 014 to reduce spasm. And with this 014, I was able to cross the arch and do a retrograde recanalization of plantar artery. And with a very small balloon, I was able to cross the arch, predilate the distal posterior tibial, and engage with the antegrade guide wire in the posterior tibial, the distal posterior tibial, and the lateral plantar. So what I failed to do antegradely, I succeed to do retrogradely. And after the predilatation, was able to advance also antegradely. So now 2 014 guide wires, again to reduce spasm, and with a 014 platform balloon, 2 millimeters, 220 and 2 centimeters final dilatation. And this was the result at 2.5 with direct blood flow in the anterior and posterior tibial with complete below the knee and below the ankle revascularization, and with direct blood flow for the forefoot and for all the toes. Remember that the setup was only angiosome concept, and I finished doing a complete revascularization because I failed to do the antegrade crossing of the posterior tibial. The patient underwent to skin graft and completely healed after 6 months. So this is what we can achieve, but not in all the cases is so easy or easy like in this case, because we have some many challenging cases in which we fail or we cannot achieve the result antegrade, and we need something different. This is a case of an 81 years old male with diabetes, hypertension, and obesity, already amputated in the second toe and scheduled for amputation of the fourth toe related to deep infection and osteomyelitis. This is the vascular situation, antegrade access in the common femoral again, some lesions in the distal SFA and the proximal pop, short occlusion of anterior and long occlusion of posterior, many stenosis in the anterior tibial, and look at the foot. We have an hypoplastic dorsalis pedis, so this is a tarsal dominance. Look, you can follow, this is a collateral, dorsalis pedis is a collateral, and what we have is a plantar dominance. So the arch finish is only receive flow through the posterior tibial. So approach posterior tibial, again V18 and 4 French catheter, again subintimal approach, that fast, very fast, allowed me to arrive at the ankle level, and at this point it was impossible to cross. In fact, I risked to damage the artery, so at this point I stopped and decided to shift for retrograde metatarsal artery access. Following the calcium, I was able to puncture in the first metatarsal artery, engage the arch. This is a V18 again, And with a V18 and a CXI supercatheter, I was able to do a retrograde recanalization of the lateral plantar, connect antegrade and retrograde axis, and go down with the 4-French catheter till the arch. I was able to inject, check that it was in the lumen. So I passed a V14 guide wire in the first toe, did the hemostasis, and with the long balloon, did the final dilatation of posterior plantar and also the SFA. This was the result, some no flow limiting dissection and direct blood flow through the anterior and posterior, with a direct blood flow through the posterior into the plantar and through the plantar into the arch, with a clear increment of the perfusion for the forefoot and for all the toes. So again, the patient was amputated in the fourth toe, and after 6 months, she was completely healed. Again, sometimes the situations are more challenging than we expect. This is a case of a lady that was already treating another center in a crossover to do the SFA. She finished with a big hematoma from the groin to the knee after perforation of the SFA. Everything was okay in the SFA right now because they put a cover stent, but the access in the common femoral artery was not possible because I was unable to see anything. She was scheduled for a transmetatarsal amputation related to the gangrene of the second, third, and fourth. And so when she arrived to my table, I was unable to puncture in anything because I was unable to find an access. So I did a Doppler. I found the posterior tibial, and what I was able to do was to perform an antegrade access in the posterior tibial, put the V18, put the microsheath, and through this, I was able to see that no vessels were patent in the foot. So again, with an 014 guide wire and with the CXI supercatheter, I was able to engage the lateral plantar, and mixing endoluminal and subintimal, I was able to finally cross the occlusion of the lateral plantar and to re-enter in the distal lateral plantar. Through this catheter I saw the arch that was very thin and diseased. So again, with an 014 guide wire, I was able to engage the arch, cross the arch, and be back in the dorsalis pedis. At this point, the guide wire, the 014 guide wire, was able to navigate in the dorsalis pedis and to go up, but unfortunately, the supercatheter was unable to cross completely the arch. So I decided to remove the microsheath and, in a sheathless strategy, to shift for a balloon. It's a 2 millimeters balloon that allowed me to dilate the arch and finally engage the dorsalis pedis, and finally dilate also the lateral plantar. The first check I did showed me that the foot arteries were already patent, but there's still some stenosis and occlusion in the anterior tibial. So I decided to cross all the anterior tibial till the ostium, engage the ostium of anterior tibial, arrive in the popliteal artery, and finally dilate all the anterior tibial to again obtain a full, complete below the knee and below the ankle revascularization. And I'm suddenly going to show the result that was, as I said, full below the knee and below the ankle revascularization. So the patient underwent to transmetatarsal amputation and completely healed after 6 months. This is our result and our experience. In most of the cases, as I showed before, patients arrived with multi-level disease, and in 96% of these cases, we are able to correct, to treat the SFA and POP, and the same in 94% of the patients, we are able to treat below the knee and below the ankle arterial disease. It allows us to obtain this type of result with very good improvement, 81% of improvement at one month, and to maintain this type of improvement with a 79% of very low Wi-Fi class at 6 months. So in conclusion, lower limb revascularization provides good technical result with high patency rate at mid-term follow-up. The clinical results are very good with 95% of amputation-free survival at 12 months, and we only have less than 5% of major amputation. And the final conclusion is that the extreme approach and extreme access, as I show, improve the technical success rate, but always remember it increases the X-ray exposition. So thank you so much, and we are ready for question and answers.
Okay, thank you, Mariano. So that was just a great overview and a lot of very challenging and yeah, amazing cases. So for the audience, so you're free to yeah, pull questions to ask directly to Dr. Palena, so we can just yeah, read this. So there were already some questions in advance. So when I just see your cases, and you said there are just some where you do not succeed, but it's hard to believe because there were so challenging cases. So where would you say, I have to stop, we don't succeed? How many attempts do you have? And how often do you just try and just go retrograde, and how many vessels or wires you would give up?
Mm-hmm. Well, many questions in one, but very nice one. I think the most important advice I can give to everyone is consider the time. So when we set up the procedure, we always start thinking to don't work more than 1.5 or at least 2 hours, because you know very well if in 1 hour you are unable to put your guide wire in the foot, probably in the next hour you will fail. So it's important to shift relatively fast from one to the other strategy. If the luminal crossing fail, shift for subintimal after no more than 10 minutes. If your 018 guide wire is not able to make the dissection, shift for an 035 relatively suddenly. How many guide wires you can use? It depends. If you fail with 2 or 3, maybe it's better to change the artery, or maybe it's better to change the patient because you are going to fail. About the failure for itself, you know there is a 20% of no option patients, and this is the patients that we are now moving very fast to the DVI, to the deep vein arterialization. It means very calcified arteries with lesser foot, with calcified small arteries that you are from the beginning knowing that the failure rate is so high. So maybe I try for 30 minutes, no more than 30 minutes. If I fail in 30 minutes, shift.
Okay, just quick brief interruption. So there was also another question just in terms of material. You just said you start with 018 first, and then so maybe what is your primary 018 wire? So I think there also from my side, there is just people want to have a recipe.
Yeah, in most of the cases, I start with an 018. The most frequently used guide wire for me is the V18, but I really appreciate also the Command 18. So both guide wires are very good. I really like V18 because allow me to work with the tip and go in the luminally, or allow me to make the loop and go subintimally.
So can you just say, so in how many percentage you go subintimally? Because the cases I saw, you just had a lot of these knuckle wire techniques, which if you just look to Asian or Japanese centers, so they will be very afraid of going subintimally, but you just have brilliant results. Yeah, so that's why.
Well, yeah, I really like subintimal strategy because it's fast. And finally, if you are going to fail, you discover it very suddenly and you shift for retrograde. So I can say that probably 70%, 70 of my procedures are approached by subintimal approach.
Okay. So how deep is the connection to your plastic surgeon?
Plastic surgeon?
Just for wound care, because I saw a lot of pictures where I think, or are you doing it? No.
No. I'm interventional radiologist. So unfortunately, I'm interventional radiologist. I work in a dedicated center for diabetic foot in which I'm just a part of the multidisciplinary team. I take care about the arteries, but there are surgeons, a foot surgeon that take care about wounds. And in 90% of my cases, the patient needs some type of wound care. because we are treating in 90% of the cases really for 5 and 6.
Mm-hmm. So there were maybe just 2 other very interesting questions. There was a question on stump. So do you have any techniques in stump occlusion of SFA when integrated of femoral or retrograde access? So do you just consider the stump? The question was referring to the CTOP classification a little bit, I guess.
Okay, so about the stump, it's very important to consider that. My approach about these cases is ultrasound guided access. So it means semiological evaluation of the groin in when you can see the common femoral debifurcation, and you can clearly see that there is no flow in the SFA. So if there is space to puncture in a couple of centimeters up, antegradially always, because you can go directly in the SFA under ultrasound, otherwise crossover. But I approach even in a flash occlusion antegradially, and for sure I believe in an endovascular approach, even in the flash occlusion of the SFA. About the caps and the CTO, as you know, I think the cap description is very nice and very useful, but I really don't follow this indication. So I mean, if the cap is in this way or that way, approach it antegradially, retrogradially, no. I always start antegradially because I believe that more than the cap, the re-enter distally depends on the skills of the operator. So I always approach or start antegradially. If I fail, shift for retrograde approach.
Okay. Another question is, so in general, how many operations in one patient per year? So in terms of restenosis, so do you have an average? So you just have very close contact to your patients? So,
well, yeah, it's a very clinical decision.
Yeah.
Even if the artery is occluded again, but the patient healed and is stable, we are not going to treat the patient again. But however, there is 30%, 20-30% of the patients that are treated more than once in a year. How many times? It depends, because there are patients that are treated twice. There are patients that are treated 4 times in a year. It depends. Means if you are able to help the patient, you are able to open the arteries, you are able to in some way improve the clinical situation, but the patient is back for a new ulcer or for no healing ulcer, we repeat the procedure.
Okay, so the main driver is the clinical situation, is just
absolutely
doing duplex ultrasound surveillance, just in terms of no wound healing or new wounds you're going to take care.
Clinically driven TLR.
There was just another question in terms of subintimal approach, that you may lose collaterals. So how do you handle this?
Well, when you approach subintimally a long CTO, we already don't have collaterals in this occluded segment. You could find someone, but I don't take care about that. The collaterals that I really take care are the collaterals that fill the distal vessel. And yes, for sure, when you approach subintimally a long CTO, you must consider the re-enter. I never push without C the guide wire in the loop-shaped tip inside the vessel if the re-enter is not a good re-enter. I mean, straight re-enter, big vessel, healthy vessel, and the collateral at least 1 centimeter down to the patent vessel. So it means you have the chance to fill the re-enter or to stop there without damage the collateral and puncturing the distal artery and go up. So subintimal is very nice, but at the re-enter point, you must focalize 2 or 3 important things. Healthy vessel, distance to the collateral.
Okay, thank you. And there were just another questions concerning the material. So can you just say, so how many times you use drug-eluting stents or stents below the knee artery? And what do you think about the use, I'm not talking about the actual situation of drug-coated balloons, but how often, or how do you think was the importance of drug-eluting technology in below the knee arteries?
About the stents, I don't like too much the stenting below the knee, because what we have are short stents to cover long lesions. So we will need multiple stents. Actually, there are micro medical stents that start to be longer and could be an option in the future, but don't have a big experience with the stent below the knee. And I can say that I'm not a believer of stent below the knee, actually. About drug-eluting technologies, yes, I really believe in that, because as you mentioned before, patients that are treated twice or 3 times in a year, well, you need to do something different for the second time. So I really believe in drug-eluting technologies for the TLR treatment in below the knee.
Okay. Just another 2 questions, which are also very good, I think. So how do you puncture directly the tarsal arteries? Because I think we've seen that you're going to really skillful puncturing techniques.
Well, metatarsal arteries can be punctured in 2 different ways. Anteroposterior view of the foot. If there is calcification, it's very easy to puncture in the calcium. You can feel the artery when you're puncturing it and put the V18 guide wire in. Or if the artery is patent, injecting a bolus of contrast medium and doing it in a direct puncture. The third option is under ultrasound, but honestly speaking, I'm not able to do that.
Me too. So I also don't use this because I'm not able to puncture these or to see these small arteries do this ultrasound. Just maybe 2 last questions from the panel here. So what's the impact of MRI in terms of strategic planning? So do you use MRI to plan a strategy?
Well, I think to have some images before the intervention can help always. But many of these patients arrive in quite emergency situations, so there's no enough time to have something more than a ultrasound. And there is another rate of patients, big rate of patients in borderline chronic renal failure, so no under dialysis, but with 1.5 creatinine, that, you know, if you need to do contrast, do it during the procedure rather than to use the margin, the volume you have of contrast doing CT scan or MRI.
Yeah. And what I also have seen, so you use the Bärenstein catheter as the guiding catheter. So do you have dedicated 018 support catheters you use with the V18? Or do you still stick to the large ones?
The most frequent situation is this combination, V18 and full French Bärenstein type 2. This full French Bärenstein type 2 is very robust, so allow us in many cases to arrive in the foot as a very cheap catheter. This is the reason why we always start with this. And honestly speaking, I'm not afraid about the gap between the lumen of the catheter and the guide wire.
But can you pass the calcium?
No, in the calcium, absolutely no. But you know, in the calcium, many times nothing is able to pass. So in the calcium, sometimes I prefer to use 018 super catheter or just start with the 014 platform strategy, and through the 014 guide wire start with Coyote 1.5, Coyote ES 1.5.
Okay, so there are several questions, but maybe we can just just keep them in mind when we also just hear the lecture from Tibor. So stay tuned. So there will be other questions also concerning below the knee artery treatment. Yeah, so I think just in sake of time, we just have to change also to the second lecture, but I think at the very end, so we can discuss still some things together. So yeah, I would just move to Tibor's lecture, and maybe you can also briefly introduce yourself. You're from a large center with a lot of patients, and with a lot of skills, that's what I know. And I think that you're facing, what I've heard, a little bit, not that much about below the knee artery, but also just of the inflow situation, and also about atherectomy devices.
Yes, thank you very much for the word, and for Boston Scientific to be able to share our experience with heavily calcified, challenging cases. So my name is Tibor Balázs. I'm an interventional radiologist at our Center of Interventional Neuroradiology and Endovascular Therapy, and would like to talk about the idea why we are using the downstaging strategy in the severe calcified lesions when we are treating critical limb ischemia patients by utilizing the jet stream atherectomy system. So as we know, on the task A and B lesions are most suitable for endovascular treatment, but on daily basis we are facing task C and D lesions. We adopted the philosophy of percutaneous atherectomy, which is based on luminal gain by reduction and modification of the atherosclerotic plaque, by downstaging the complexity of the lesion and changing the vessel compliance. We try to reduce the dissections, additional vessel barotrauma and bailout stenting, and we try to make the vessel more compliant for adjunctive treatment options. We are using DCB after the atherectomy. So these are the challenges with the complex lesions, especially with the well-known Fabrizio-Fanelli study. In case of circular calcification after balloon angioplasty, the primary patency drops down, you are not able to dilate the lesion, ends up with dissections, perforation, distal embolization, even ends up with a suboptimal stent expansion. As we know, the balloon angioplasty is based on mechanical plaque disruption. We are displacing the plaque within the arterial wall, applying longitudinal stress, radial expansion stress, and shear stress during the opening of the balloon itself, and end up with dissection, which is reported between 50 and 84% of the time. So there's a clinical impact with these dissections. It was investigated by the large multicenter study by Fujihara with almost 750 cases of the lesions. There was, after initial balloon angioplasty, 84% cases there was dissection. These dissections were graded into 7 types. From A to F, and the severe dissection, so type C and greater, were associated with a higher restenosis rate and TLR rate. Even mild dissections can end up with let's say, early restenosis, especially longer lesions, longer than 10 centimeter lesions can be associated with restenosis as well. On the other side, there is endovascular atherectomy, which provides the theoretical advantage over balloon angioplasty. The plaque is removed rather than pressed against the arterial wall. So by changing the vessel compliance, there's a change for a more uniform angioplasty, result with a minimal consequent vessel barotrauma. We're improving the luminal gain, decreasing the risk of plaque recoil and dissection, preventing negative remodeling and neointimal hyperplasia. So this is the example, task C lesion. It was a 74-year-old patient with critical limb ischemia, rather for stage 4, with rest pain, prolonged healing of the venous ulceration, anchor regular index 0.5. You can see here the occlusion of the mid-SFA with the stenosis proximal distal part is longer. The distal runoff, we use the filter and remove the plaque by utilizing the jet stream expandable cutter. And after the plaque removal, apply the DCB with this final result. The same sequence was repeated on a popliteal as well. Another case, the long segment of occluded popliteal and the below the new vessels, you can see. For recanalization, we are using the same 018 wire with a 18 support catheter. Once we enter the ATA, we remove the wire because the device itself is running over 014 wire, and utilize the jet stream single cutter 1.85, and this is the final result after the atherectomy and adjunctive balloon angioplasty. So the jet stream catheter is designed for differential cutting, offers front-end cutting with circumferential rotational clearance. You have the chains for expandable cutters. So if you open the blades, you can open the vessel even more. You have the active aspiration feature. So the devices have an FDA approved for thrombus aspiration. So if you are not sure what is the age of the CTO, because we never know which part is severely calcified, where is the fresh thrombus, this device can handle both part of let's say, the world. So this is the case of the vessel modification the heavily calcified proximal poplita, 79 years old, high-risk patient, with clinical signs of severe limiting claudication, breast pain during the night and in the left calf, with diabetes, end organ damage, post-myocardial infection, 3 vessel disease. So it was a really sick patient. It is important for the next phase. You can see here we made an angiography examination. There was a question from how we start let's say the procedure. So first thing first, it's important to make ultrasound examination to see which approach is the best for the treatment. If you have space, it's always good for integrated approach to have more control when you are crossing the lesion and to see what's happening below. So this is the lesion itself with one vessel runoff, and this is the case itself. So you can see how heavily calcified the poplite was, and in these cases you are just overinflating the balloon proximal and distal to the lesion with a higher rate of perforation, and you can see the elastic recoil immediately after the procedure. So there's the question what to do now: is send the patient to the surgical ward, or you can utilize the advantage of the atherectomy and remove the plaque. So after the filter placement, we use the JetStream 2.1 to remove the calcium, and you can compare the superficial calcium removal in between the pictures B and E. The balloon is more compliant after balloon angioplasty. So here we see the advantage of the atherectomy. If the plaque is so heavily calcified, you are not able to move it from side, and then the better idea is to remove it to keep the flow and to have luminal gain. This is the final angiography, improved below the knee result, and from the posterior tibial there's ADP filling as well. So the JetStream calcium study investigated the effect of the catheter by IVUS investigation before and after the treatment, and the conclusion was the JetStream atherectomy system removed and modified superficial calcium to achieve significant luminal gain. There are several randomized controlled trials comparing atherectomy with angioplasty. The result was the atherectomy plus angioplasty resulted in significantly less Balázs stenting, but with cost of a higher macroembolization rate. If you see the compliance study, it was with a heavily calcified lesions. The Balázs stenting rate was 5.3 at the atherectomy side and 77% in the PTA alone. It's interesting that just 4 atmosphere was enough to dilate the lesion in the atherectomy group in comparison with the PTL and alone group where you need to go to higher atmosphere, 9 and more. On the other side, the 1-year patency is quite similar between both groups. So in order to improve the long-term patency, in the definitive IR study, the atherectomy was followed by DCB with a result 82% primary patency versus 71% in a PTA group. So there's a trend in potential better outcomes in challenging lesions, such as severely calcified lesions, 10 centimeter and longer lesion, and CTOs. Proper technique is essential for optimal result. So this is the case of the occluded SFA. Ralf, you mentioned the preservation of the collaterals as well. So this device is, for example, quite handful when you are using it and removing the plaque. So the chance for interluminal recanalization and opening up the vessel with preserving the collaterals is always beneficial for the future. Usually we are using 018 wire supported with a 4 French, is the Bernstein catheter, and after exchanging the wire to 014, we are treating the lesion, but not at once, so not a full length, but you can see the red arrow, we are keeping the distal part closed to avoid distal embolization, to act as a filter, so you can work on the proximal part and to see what's happening if the inner surface is smooth or it's chunky, and you can decide at this phase to put a filter or not. And this is the final cap removal and balloon angioplasty with a DCB, the final result without distal embolization as well. So in our opinion, the best patients or subsets are the long CTOs with or without thrombus, the no stent zones. So when you don't want to cover one or another vessel with stent, you have the high-risk patient for surgical, you have the contraindication for dual antiplatelet therapy, or below the knee when you are facing with really heavily calcified occlusions with really tough proximal cap, and you are not able to enter it just with a wire, you can utilize the catheter with the front end cutting to open it up, and then you have the instant restenotic lesions and occlusions. So this is the example of the bifurcation lesion. You can see the heavily calcified origin of the profunda and the SFA. Once we cross the lesion, we perform the atherectomy as well. Then we cross the SFA and opened up. Importantly, we are communicating with the surgeons as well. Typically, these patients are best suitable for surgical option, but in this case, the patient was obese and refused surgical approach. So we, after discussion, used the atherectomy to remove the plaque, and after double balloon angioplasty, opened up the vessel. Another case, it was a 68-year-old patient with a CLI, rest pain in the right foot, again bifurcational lesion. So you want to decrease the risk to create a dissection, to end up with stent implantation in this region. So you can open up the vessel to ATA, then move to the tibial trunk and open it up, then balloon angioplasty, and this is the final result. This is the case of the instant occlusion. Usually in this type of lesions, you have some thrombi inside, neointimal hyperplasia, and it's always beneficial to use some device when you're opening this vessel with active aspiration. So again, the recanalization was done by V18 with O18. This was a trailblazer support catheter. Again, the lesion was not treated at once, but we kept the distal part closed to act as a filter. Usually, if you have a full occlusion, you can send down the diagnostic catheter, using the same trailblazer, to fill up the space with contrast to see what's happening inside. So the thrombi were removed. You can see the tight stenosis in the proximal part and the occlusion on the distal part. So then finally we removed by blades down the distal cap. It's always important to move the catheter really slowly to avoid stalling the device, to allow room for expiration. You have to hear the voice. If it's lowering, then you have to wait a little bit or a little pull back to gain full rotation, and you can then enter the lesion. In this case, we finished the case with a DCB balloon angioplasty with this final result. The last patient, this is a 67-year-old patient with a critical limb ischemia with Rutherford stage 6 with gangrene of the digits. You can see really sick disease below the knee vessels. And in this case, after antegrade approach, just enter the lesion with a wire. So if you are facing with this case and you want to finish the procedure from antegrade approach, of course, you have the opportunity to use it from retrograde, but another option is to use the front end cutting of this device and finish the procedure from the proximal puncture. And this is the final picture. So we know from the recently published and presented trials that atherectomy can accomplish the task of vessel preparation, clearly reducing the dissection rate and bailout the stenting rate. The proper technique is essential for excellent results. So slow advancement of the cutter, avoid stalling of the device, room for respiration, and in our opinion, in our practice, the embolic protection device have added a level of protection to the outflow vessels when you are treating irregular, heavily calcified lesion, so instant restenotic lesion or TAS-ZD lesions, and you have to respect the limitation because no single device is right for every case. And we see the future in combination of debulking, atherectomy, and drug-coated balloons, and there's a promise, early promise in early studies, especially in the treatment of more complex lesions. So, and now the questions and answers. Thank you.
Thank you so much, Tibor. So, very beautiful scenery.
Thank you.
nice hospital. Okay. So there was just already a question from the audience. So is Jetstream contraindicated in subintimal PTA? Are we sure that we are not subintimal? So how do you deal with this, especially in a CTO case?
Yes, it's a very interesting question. Usually, I am looking for my wire, how is acting during the recanalization. If the wire is going quite straight, because we do not have IVUS in our cath lab, so I'm just following the wire, the behavior of the wire. If it's creating a loop or it's really bending, then there's a really high chance that I'm subintimal. And in this scenario, if, for example, when you are treating long lesions, then and you are not sure in the distal part, in my opinion, we are using the Jetstream proximal part, because even if you are not using it in the whole part, you are reducing the chance or increasing the chance of the procedural success, and at the part of the dissection, just balloon it. That would be my, let's say, advice.
Okay, thank you. And what are the limitations of this device? So are there situations where you say, I would not use it, or otherwise, so are there clear indications where you say, no, I would always try to debulk by Jetstream?
Okay, so what we see in our daily practice, I like more CTOs, because you can use this distal cap feature. What I have respect when you have really one-sided irregular plaques, especially long SFA stenosis, when there's a chance that we will disrupt the surface of the plaque and might cause embolization. So I would advise, if you would like to start with a Jetstream catheter, I would do let's say 10 centimeter long CTOs of the SFA, and then go for more complex lesions. So the device itself is can very nicely treat centrostenotic occlusions as well, and we used it, but it's our experience. We had an older bypass occlusion when the device itself can quite handle the older thrombi, aspirated, and then you can finish the procedure by balloon angioplasty.
Okay. There was a question on complications. So what are typical complications, and just in percentage, how often do you face or have to prevent a complication?
Okay, so the let's say most common one is reported 1.8% is the distal embolization. So we are preventing it when we are facing with a severely calcified lesion, and we assume that there will be a longer running time. Then we put a filter distally to the lesion to preserve the distal vasculature, especially when you have one vessel runoff. But the other complication might be perforation of the vessel, but we had this scenario just in one case. It was a really eccentric plaque, so I would avoid to treat really eccentric one-sided vessel or plaque, because on the other side, because it's a rotational device, you can harm the healthy part of the vessel, and let's say with one rotation or removing the plaque, on the other side you have the bloodstream. So I would avoid this type of lesions.
Okay, and another question was just, how far distal do you go with the Jetstream? So where do you stop?
Okay, so there's a, let's say, 1 millimeter rule of the device. So if you have wide enough below the knee vessel, so you can go even to the level of the ankle. Let's say you have to avoid to cross the lesion or go further when you have an angulated vessel, because at that point you have friction and you might cause the perforation. So that would be one limitation, but the catheter is really long, and if you have an antegrade approach, there is no limitation. Just you need a room for the catheter itself to be able to rotate.
There was another question, so thank you. In terms of stents, so when you decide to use a Jetstream device, so in which percentage do you think you still need a stent, or is this something, a 100% stent avoidance strategy?
Okay, if we see our cases in heavily calcified lesions, more than 75–80% of cases you have to put a stent. But if you are removing this burden, you are ending up in between 7 up to 10% of the stent ratio, let's say. So we really improved in that field with a heavily calcified SFA popliteal lesions.
So you definitely need less stents.
Yes.
And so you just said that this combination therapy with drug-coated balloons is something promising. So maybe just also ask Mariano, so you both think that this, if you just combine drug-eluting technology with atherectomy, so do we have data, or does this affect the outcome?
Okay, so we have data from a definitive IR study where the authors used the atherectomy device and followed by DCB. The patency was around 82% 1 year, in comparison with just DCB alone 72. So there was really there's a pattern that it might be better, but it depends on what is the technique, how the device is used, with which type of lesions are treated, because you can see, especially with directional atherectomy, you can really create deep cuts, and in these scenarios, it was an interesting study from Dr. Choppa, where they used directional atherectomy for atrauma removal, and then they sent it to histopathological analysis, and they found out with deep cuts with the media and the the restenosis rate was really high, and in comparison with just the intimal removal, there was over 91% of patency at 1 year.
Okay, good. Yes, thank you. So we are just at almost coming to an end. So if there's something very important from your side, just feel free to just give a comment. Also you, Mariano, if you just have anything.
Well, just about the last question, I fully agree with Tibor. Every time I use an atherectomy device, and I really believe in the use of it, I combine it with drug-coated devices, drug-coated balloons. And another mention about how we can be sure about the crossing walls in the luminally, well, about the type of guide wire we use, about how we push the guide wire. But a question for Tibor: do you believe we can check it using external ultrasound?
Oh, it's an interesting idea. Yeah, to see if you are intraluminal. So that's another option, definitely.
Because I saw the work of Shihab Mustafa that he used frequently. He has a specialized technician helping him, but he used it to cross and to be sure that he is in the lumen. So sometimes, even if you are not following the guide wire, you can check it with an external extra body ultrasound. So just a Doppler, and you can see if the guide wire is in the lumen or not. Could be an idea. I don't have experience.
Yeah, I think that's
a good idea.
But I think I personally also think you need someone to help you, just as a technician or just a colleague. So you need more in terms of facility. Yeah, so maybe I try to summarize your lectures or just the main topics of today. So what I think was very interesting from Mariano's talk was just the no crossing, no party, which I think is really the fact. So I think we just have to spend a lot of efforts right now, especially when we talk about CLI patients, which mostly are going to have a CTO, that we really urge to have good wires and just wire skills and a good technique, which is also covering the axis. So that's what I think you have shown brilliant, that there is only not one axis. Sometimes you need 2 or even more axes by retrograde axis or transpedal or transmetatarsal punctures, just to succeed to cross a wire and just to pass a lesion. Which I think no crossing, no party, and also almost never give up. But what I think was also important, that there is a time frame that you are giving yourself where you also have to stop. Even although you have a lot of skills, you say, okay, after maybe 2 hours, you probably stop if you do not really succeed, and then maybe reschedule a patient. So we didn't talk about this topic, but also probably to transvenous arterialization, just to change the strategy entirely if you're not able to cross. And I think if you just follow these strategies, you're maybe also able to have these impressive results with a very low amputation rate of almost 5% after 12 months, which is very low in this subset of patients you have. And just to lead to a dramatically downgrading of severity of those CLI patients to a much lower Wi-Fi class. So that's, I think, quite important. And if I would just try to summarize Tibor's lecture, I think it's just, in CLI patients, we just have to conquer calcium, which is, especially also in Berlin, we just have this problem. Sometimes if I see the Italian patients or the Italian strategies just to cross the wire, I think it's due to olive oil. So it looks a little bit more like glue, which is not true. But we just have also very calcified vessels. And we also think that we need some atherectomy devices to remove this calcium. I found this very helpful because filters are expensive, and atherectomy devices like Jetstream per IVU, you don't have to use the filter with it. But I think it's going to help you just in terms of to overcome complications. And there are several cases, a lot of cases where you need a filter, but the strategy just not to totally cross the lesion, then decide whether you're going to need a filter just in terms of the appearance of this lesion. That was quite interesting. And I think if we just look at the cases you did and you showed us about the indications, I think it's quite useful in a lot of indications, especially in CTO cases. That's what you have shown in calcified cases, and in cases of no standing zones, and also in regions where you which are just surgically not fit for surgery patients, like this common femoral and deep femoral osteal lesions. And that's just the next topic, just bifurcation lesions, where you're just afraid of plug shift or losing the one or the other artery. That's, I think, also a very helpful tool. If you have a wire passage, you just can open both arteries by atherectomy, and that's also very interesting, the trifurcation or bifurcation below the arteries. So that's quite helpful. Yes, so there is a last question also, or a last polling from our side in terms of, so maybe I can just try to get my screen. Yes. Yeah, so as a polling, so how would you rate this webinar? So there are just some options. I hope it's like with you, so that you are that you learned a lot. So I just, from both of the lectures, I probably took a lot of to my practice today. Thank you for your cooperation and just pulling questions. So I think it raised your interest, and it was, thank you just for the webinar. So the was rated as quite extremely valuable and some good information. I think in terms of this global exchange, I think it's quite important. If we just this topic of CLI fighters, I think it's a nice wording, but it's really like a fight, and I think we just have to cooperate and just stand together and also exchange strategies, technology, and also our experience. And thank you so much. So I think I will close. Thank you, Tibor. Thank you, Mariano, for these very valuable input. And once again, thank you for Boston Scientific to giving us this opportunity to exchange our knowledge and just to discuss, not only on conference, but on this webinar, our experience with these very, very thick and very severe patients.
Thank you very much.
Thank you, Ralf. Thank you very much to everybody.
So we'll close the session. Thank you so much.